Hi, everyone, and welcome to another episode of A Doctor's Insight. Today is all about a job in endocrinology. And to talk to us about that, we have Dr. Andrew Lansdown. So he's a consultant physician and endocrinologist at the University Hospital of Wales since 2016. He's served as clinical committee member with the Society for Endocrinology and has sat on the Royal College of Physicians' New Consultants and Joint Specialty Endocrinology and Diabetes Committees. He also serves on the RCP Wales Executive Group and recently has taken up the role of RCP Regional Advisor for South Wales Central. In addition, he's an honorary lecturer with Cardiff University School of Medicine, involved in the undergraduate teaching program and examinations. He's completed his research MD in polycystic ovary syndrome, particularly focusing on the cardiometabolic risks associated with the syndrome and central nervous system control of blood pressure and insulin resistance. He's published papers in various aspects of diabetes and endocrinology and has co-authored a textbook and book chapters in the field. He also was an author for the UK Oncology Nursing Society guidelines for patients with endocrine complications related to immunotherapy and has ongoing research interests in aspects of pituitary, thyroid, and adrenal disease. So thank you so much for joining us today, Dr. Lansdown.
Thank you for the invitation, very kind.
Of course. So we can just get straight into it. And can you start by telling me what a typical day or week in your job is like?
Sure. So I obviously practice here in Wales in the UK, and you'll find that most endocrinologists are dual trained, so they practice in diabetes and endocrinology. I'm fairly unique, certainly in Wales, that because I work in a tertiary centre, I practice just the endocrine side and not so much the diabetes. But you find that endocrinologists, diabetologists are also trained in general internal medicine. So they're general physicians. I'm a general physician as well as a specialist. So I think that's part of the attraction of the specialty. So my job really entails both the specialty and internal medicine and attach that acute medicine. So the week can vary, but there are usually fixed commitments each week. So you have fixed clinics. So for example, my week often begins with a new patient clinic on a Monday morning of new endocrine cases, either referred by general practitioners from the area, but because we're a tertiary centre, often referrals from other secondary care centres across Wales. And we see a lot of pituitary disease as well, because we're the only centre here that operates in Wales on pituitary tumours. So it can be a new clinic, and then, for example, later in the week, I have a follow-up clinic Thursday afternoon of our general endocrine patients. Friday afternoon is my thyroid clinic, combination of new and follow-up patients. And then every other Tuesday, I have a follow-up clinic of endocrine patients. That's the specialty. And on top of that, I also am involved in multidisciplinary team meetings. So for the specialty, we have three main MDTs that I'm involved with. One is an adrenal MDT, so we meet once a month, myself with the adrenal surgeons, the radiologists, and we discuss cases of adrenal masses that are referred in from across South Wales. And then I'm the lead for the pituitary MDT, which again is once a month, and cases from South West Mid Wales are fed into that. So we discuss all sorts of cases like acromegaly, Cushing's disease, non-functional adenomas, and so on. So it's a very interesting part of the job. And the third MDT, which is a weekly one, has only been running for just under a year now, is with the Velindre Cancer Centre in Cardiff. So it's a fantastic opportunity for collaborative working. Um, you may have heard of the immunotherapy, so the immune checkpoint inhibitors, which have really revolutionized cancer survivals, particularly things like melanoma, but they have lots of side effects, including endocrine side effects. So part of my role now is a weekly MDT discussing the kind of endocrine side effects of that. So that's specialty work. We also do a specialty retrieval at the front door, so I'm on a rota for that. So perhaps once every couple of weeks, I'll be at the front door first thing in the morning, um, picking out patients with diabetes endocrine problems that we can hopefully turn around from the hospital fairly rapidly and provide specialist input. Then the general medicine side, Alongside that, I cover the ward here at the hospital. So I'm in charge of a acute medical ward or general medical ward. I tend to cover about half the year on the ward and half the year I'm off the ward. And again, that's a range of medical cases. So that's not just endocrine. We see a lot of infections. These days, a lot of frailty, an aging population, comorbidities, often cancer, new diagnoses or complications relating to that. So it's quite a wide spectrum, which is, really thoroughly enjoyable. And then I also have a commitment to the acute on-call rota for medicine. So that's 1 in 17, something like that, which is not too onerous, but very enjoyable as well, because you see really very much acutely unwell patients at the front door, referred from A&E, referred from GPs. And again, it's very much a broad range of presentation, and you get to make an acute management plan. Some you get to send home, some you have to admit to hospital, but that's both rewarding and enjoyable. So that's a brief overview. There's lots of other bits involved in that, but that's kind of a typical timetable.
So a typical timetable does sound quite busy, and it sounds like you wear a lot of hats as well. But if we stick to the endocrinology hat, can you describe some common presentations that you may see, how patients would typically present to you?
Yeah, so I mean, we see a range of things. I mean, there are common things to us in endocrinology that we see. For example, in the thyroid clinic, primary hyperthyroidism is a common condition that we treat, and it's commonly either Graves' disease or the autoimmune presentation, or nodular thyroid disease. And the patients will present usually symptomatically to primary care, typical symptoms like sweating and weight loss, unintentional weight loss, tremors, anxiety, and so on. Have the blood test with a GP. Sometimes management is started with the GP and then they're referred into us. So that might be a common presentation we would see. Another common general endocrine one might be primary hyperparathyroidism, so high calcium from parathyroid adenoma, polycystic ovary syndrome, which affects 10 to 15% of young females. So we commonly see females presenting with menstrual disturbance, hirsutism, etc., which is a common condition that we treat. Increasingly, and we see a lot of this in endocrinology, is the results of, I don't want to say over investigating patients, but we live in an age where, for example, lots of people are scanned. So I get a lot of referrals of patients who are found to have, for example, an adrenal mass they knew nothing about, but they've come in perhaps to A&E with appendicitis, they've had a CT and it's picked up an adrenal mass. So lots of incidental findings. And I think we see a little bit of that with blood tests as well. See that with head scans and pituitary masses. So they're the more common things. And then rare conditions that we see here, things like Cushing's disease, acromegaly. They often present to their local hospital, and they're referred into us for surgical management. And it's classic, it's fascinating to meet these patients, but you see classic things like the proximal muscle wasting, central adiposity, sometimes very deep red, wide purple stretch marks, easy bruising, moon face type picture, and classic picture of Cushing's that you might see osteoporosis in a young age, hypertension. I remember one patient presented and they worked in a job where they had to climb stairs a lot and they really struggled with that. And that was the proximal muscle weakness. So it's really interesting that you're seeing things that you've learned perhaps in med school, and you're seeing these classic presentations before your eyes. And the wonderful thing is that, of course, we can cure these things.
And it sounds like there's a lot of investigative work that comes along with being an endocrinologist. And how about the practical and procedural side of things? Do you have a lot of that?
No. In a word, no. And I think maybe that's the divide for physicians. I would say if you want a specialty with procedures, it's not really the one to come into. So it's quite a traditional specialty in terms of the the physician, and our tool maybe is our brain and our hands perhaps, but not to do procedures for examination. So it's often about history taking examination, thinking through those things, differential diagnoses and investigations, but there aren't really procedures that you would undertake as an endocrinologist, which I'm thankful for.
So that's something
It's
to
partly
bear
why I
in
enjoy it.
mind.
Yeah.
Perfect. And what is your most enjoyable part of the specialty?
I think I would say it's quite a generic answer, but I think it's the fact that it keeps me interested. Um, when I was deciding on whether to pursue, whatever specialty in medicine, what was I going to do? I faced a bit of a problem because I'd rotated as, I don't know, it's SHO level through so many specialties, and I loved them all. There
Mm,
wasn't really anything I really disliked, so I liked everything I had done. So I was faced with a bit of a dilemma, and I think I realised then, particularly sitting in with somebody who inspired me quite a lot, that actually endocrinology is multi-system involved. It's not just focusing on one organ; it's the whole body and how the systems interact. And alongside that, there were aspects of it I really didn't understand. I didn't get at all. And confession time, my worst subject in medical school was the one I hated was endocrine. I didn't get the feedback loops and things. So don't write off any specialty too soon. Maybe that's a lesson to learn. Um, but in the end, I think I realized there's a lot in endocrine I don't understand. And I think the natural thing in life is to avoid things we're not comfortable or don't understand. But actually, if you find a specialty that's going to really stretch you, and I've been a consultant now only 7 years, but there's still so much I don't know and so much that's advancing. And so I have to reach for the textbook and look at basic things again. So to find a specialty where you're not going to get bored. And I think that is the thing in endocrinology. There's always interesting cases, so much more I need to learn, add to my knowledge and skills, and a lot that fascinates. Um, maybe that's not the right answer the sort of answer you're looking for, but I think that's a generic answer, something that fascinates me, keeps me interested.
yeah, I like that answer actually, because you also made the point of doing it because it's interesting and you never get bored. And even when you don't know the answers, that might be someone's reason to shy away from a specialty. But in your instance, that is why you veered towards a specialty. So that's quite a unique perspective that I haven't heard of before.
Mm.
And on the flip side, what is your least enjoyable part of the specialty, if anything?
Oh, probably sounds too cheesy to say nothing. I suppose the only thing with endocrine, as you've touched on, we do a lot of investigations, a lot of blood tests, so basic blood tests, dynamic blood tests, a lot of imaging of glands and so on. So often if I see a list of patients in clinic, I've got quite a few results to chase, and that can all add up over time. So it's keeping on top of your results and chasing that, which is interesting because it's nice to look at the results and work through things, but there can be a little bit of behind the scenes, quite a bit of behind the scenes work in keeping on top of all your tests for your patients, especially if you need to alter management before they next come back to clinic.
Mm,
And these days we're doing a lot of telephone clinics, which work really well for some aspects. But the downside is that often perhaps you're sending out a blood form to the community. You don't know when that test is going to be done. So it could be a little bit of chasing results and things like that, which I don't mind at all. But that can be fairly a little bit onerous at times. Yeah.
especially when you have a lot of patients to see, I can
Mm.
imagine. Mm. And are there any resources out there that you can recommend to anyone interested in endocrinology?
Um, so the Society for Endocrinology is a really good place to look. They've got a good website. There's a section there that has got, I believe it should still be there, it's a careers booklet, in a career in diabetes endocrinology. So have a look at that. You might even spot me in there. I think I might still be in there for my SPR days. Then I think about, sometimes they have taster days or taster evenings. The society put those on, or sometimes local medical schools and so on. So try and attend those, speak to people in the specialty. But the most important thing I would say is try and go along to perhaps endocrine diabetes clinics when you get the opportunity. I think one of the disadvantages of diabetes endocrinology is that because it's largely an outpatient-based specialty, and I think because they're on the ward and they see a lot of general medicine, they might see the odd patient with a diabetic foot ulcer or DKA, and they think, oh, that's the specialty. But actually, all the fascinating acromegalics and Cushing's disease and MEN1, all sorts of things, that's in the outpatient setting. These patients don't come into hospital. So just go and sit in. Don't even have to see patients yourself. Just go and sit in with an endocrinologist who loves their work. Right? Hopefully you find that's most endocrinologists. And just see some patients, because that's what I did, and that's really when things started to fall into place and I realized actually I would enjoy this specialty.
I find that that's the most common answer that any guest gives, which is just try to get first-hand experience, because you can watch videos, read textbooks, but there's nothing like actually getting that experience and sitting in clinics or going to the hospital. So that's something to consider as well. And what is the training pathway like?
Yeah, so of course, in the UK, you do your foundation training, so F1 and F2. Often, a lot of people take F3 years now, don't they? It's become much more popular. People perhaps go abroad or locum work and have a little bit of a break. But following foundation, you have to enter internal medicine training. It's slightly changed the past few years. So you do kind of 2 years, IM1, IM2, a lot of general medical specialties. So you'll rotate, depends if you're in Wales or England, how many months you do, whether it be 4 months or 6-month rotations. I mean, a variety of specialties, but it always includes some ITU experience, some geriatric experience. And during that time, you're expected to maintain a portfolio, work-based assessments, reflections, you get feedback from consultants, supervisors, reports, and all sorts of things. Practical procedures you have to learn to do during that time in medicine, things like lumbar puncture, central venous access, and so on. And also the main thing is sitting your MRCP, so you sit your membership exam to become a member of the Royal College of Physicians of the UK, which is 3 parts. So part 1 and part 2 are written parts. Part 1 is a little bit more basic science, part 2 is a little bit more clinical, and then you've got what we call your PACES exam, which is a bit like an ISCI, and there's different aspects of that, so cardiovascular, respiratory, neurology, gastrostations, communication, history taking, that kind of thing. So you've got those 3 parts, and then if you pass all 3, you get your MRCPs, you become a member of the Royal College of Physicians. So that's IM1 and 2. IM3 is a newish thing really the past couple of years, in that it's between SHO and registrar, so it's a bit like a senior SHO, so you're doing a bit more medicine, but starting to act up as a medical registrar, especially on the acute takes, overseeing the take, senior decision making, perhaps seeing some of the sicker patients and so on. And then following that, you then apply now and you come into diabetes and endocrinology at ST4 level. And that's a 4-year program in the specialty. And again, during that time, you still do internal medicine, because at the end, you're expected to qualify and get what we call your CCT in internal medicine. But alongside that, you do your specialty. So you'd rotate through a number of hospitals in your particular deanery, so wherever you're training. So in Wales, you could be in south or north, rotate through, but other parts of the UK, perhaps a smaller geographical area. And during that time, you also sit a specialty exam in diabetes and endocrinology. That's just a written exam. and then at the end of that, you're ready to become a consultant in diabetes and endocrinology and internal medicine. The other thing you can do, a lot of people, I say a lot, I'm not sure what proportion now do it, I certainly did, was take time out to program. So you're still partly training, and some of that counts towards training, but you might take time just to perhaps do some research, whether you want to do a PhD or an MD. You can do things like out of program, just experience. It might be a fellowship. You might go away for a year somewhere and get experience in another, perhaps large centre, with an area of expertise you're interested in. So those kind of things you can build into that training as well. So, I mean, on average, that is going to take you really, anything upward to 10 years, 5, 10, up to 10 years by the time you've done all that. It certainly took me over 10 years by the time I'd built in kind of my research time as well.
So I guess it just depends on what you do in between those years, as you said, with the research and things like that. Um, but from what you're saying, it sounds like it's a pretty manageable specialty. When I think about, neurosurgery and cardiothoracic surgery and all those specialties, you hear that the workload, the hours are really intense. So with that being said, what would you say are like some of the professional and personal sacrifices to consider if you're
Mm.
thinking about going down the endocrinology route?
Yeah, I would say one thing that puts a lot of people off is becoming a medical registrar, because you find the medical registrar still takes on a lot for the whole hospital. Um, they're carrying that medical reg bleep, and that they're almost kind of the go-to person for so many emergencies across the hospital. You're obviously leading the cardiac arrest team when you're on call. You're being called to see some of the sickest patients across the hospital on the ward. It's a lot. It is quite a demanding role, as a med reg, and I think the medical internal medicine training, it depends what you compare it with, but it can be quite demanding as well, doing all your on-call shifts, because you're doing for a number of years, and sometimes into your early 30s, you're still doing early mid 30s, you're doing nights and weekends, and you're kind of sacrificing sometimes, I guess, it's going to be a degree of social life, for those years. But on the other hand, if you enjoy it, it's very, very rewarding. And I looking back, I don't think I ever was unhappy with what I was doing. I really enjoyed it. You get difficult days, of course you do, in every job, but to come out, especially when you've been a med reg and you've had a busy take, but you've managed to organise it and treat the sick patients, get them stabilised. Some have gone to ITU, some are on the ward. You've kind of managed the post-take round. If it's quite satisfying, there's something about that you feel you have made a difference. And as well, an important part I always found was making sure your team is happy and together, on call. It's really important to make sure you care for your colleagues. It's an important part of the job. I think the hospital family is really, really important. I can't remember your question now. So
No, that's okay. Just
what
like
did you ask me?
the
I've gone off.
sacrifices.
The sacrifices. So yeah,
Yeah.
I would say that would be the thing in terms of probably the demands, because people find it stressful, and it's a lot of shift work for many years. But I would say it's worth the sacrifice, because when you become a consultant, which is usually in your mid 30s, you're there then for the rest of your career, and you'll never carry that med reg bleep again. Well, it's very unlikely you will, unless you're somewhere where you're short of a med reg. And you're just doing your own calls. You've got a team under you. You can shape your service. You're doing your specialty, and your on-call commitments aren't that much. And you're not really going to be called in the middle of the night. Not like perhaps a surgeon to come and do an operation. So it's a nice work-life balance as an endocrinologist. So I think sacrifice is worth the sacrifice earlier on, to get where you want to be then for the rest of your career, which is a lot demands with it. Don't get me wrong. I've got to be careful what I say on the podcast, but but on the other hand, you're doing something you enjoy and that is rewarding, I think, and a career that is really fulfilling.
So it's just getting past that hurdle of being a med reg and focusing
Mm.
on the consultant role, which is, as you said, the role you'll be in for the rest of your career, really. And are there any important factors to consider when you're thinking about any specialty?
So is this within the medical specialties now, are you thinking, or more broadly than that?
More broadly, really.
Yeah, so I mean, often one of the great divides is whether you stay in medicine or surgery, and you'll soon work out what you want to do in that sense. I think I knew that from day one of a house officer in surgery.
Hmm.
I just didn't really particularly like being in theatre. I'd rather be on the ward,
Yeah.
sorting out the ward jobs. And I used to go up to theatre, and they were great. It was a smaller DGH, and they would have let me do a lot if I'd wanted to, but I wasn't that keen. And I remember standing there holding a clamp for about 3 hours, not seeing anything that was going on, just getting frustrated. So I knew it wasn't really for me. So that's one big divide. You'll soon work out that, and particularly if somebody who wants to work with your hands, you've got that skill as well, as compared to the medical side. Then I suppose the other big divide is primary care versus secondary care. So, and a lot of that comes down to preference. Actually, I for a while, and certainly when I qualified, I wanted to, well, I thought I'd become a general practitioner. But I did more medicine, and I thought, oh, hang on, this is quite interesting. I quite like it. I like working in a hospital setting, and I did more exams, more jobs, and I've just loved it ever since. Um, I think sometimes people can choose primary care versus secondary care, sometimes for work-life balance, although it's not easy in primary care at all, it's challenging, but I think certainly the training aspect, because you're not having to do the length of time, perhaps the nights and the weekends, all the long inclined to that. So those big things to think about. But they're probably the big divides really in terms of choosing specialty. So, and then within medicine, it's perhaps if you like procedures, if you prefer procedures, you might prefer something like respiratory or gastroenterology. Whereas
Mm,
if you don't, you might end up, and you like all of medicine, you might end up an endocrinologist or a geriatrician.
yeah. So, yeah, those are important things to think about as well. And would you have done anything differently if you think about um, your journey to becoming a consultant?
Um, the only thing which I think is a weakness really, is that I've only ever worked in Wales, and I've only ever trained in Wales. In fact, I'm working in the hospital I was born in. So
Full circle moment.
yeah, I've not gone that far sort of outside of Wales in terms of clinical work. So I think that is a weakness perhaps in my training. Um, it's good because I know Wales well, and working here now in the tertiary centre, I've got links with everywhere, and I've know people all around the place. That's a good thing in terms of the practical side of that and the networking. But I think perhaps some experience outside the Welsh NHS setting perhaps would have been something of advantage. Um,
So is that
that's
something
probably
that you
the,
would
that's what.
recommend?
Sorry, Chantal.
Sorry, is that something that you would recommend for any medical student or junior doctor then, that they try to pursue in some part of their training um, outside of where they graduated, for instance?
Yeah, yeah. I mean, I don't think it's essential, but I think it does just broaden your horizons a bit and brings fresh ideas and different ways of working. I mean, even within Wales, I think working in different hospitals has been a really good thing, because you go to different places and you notice strengths and weaknesses. So you can bring those ideas with you then when you become a consultant. But I think certainly working in different settings, healthcare settings, even outside of the NHS is or across the world, and as I mentioned earlier, F3 years are often a good opportunity for that. But I didn't do anything like that, so that's probably a weakness. But I recommend if you get the opportunity, but it's not, I don't think it's mandatory.
Mm-hmm. It'd just be, an addition, something else you can say that you've done. Okay.
It would, yeah, some extra experience, I guess.
Mm.
So I think once you become that consultant, you're pretty much in that role then. I mean, opportunities do come up for secondments and other roles, but the time to do it is when you're young. I sound like an old man now, but the time to do it is when you're especially when you've got those opportunities. Sometimes you've got less ties, you've got more energy, more enthusiasm, and the opportunities maybe to take time out to program to go and get experience elsewhere is more offered to you on a plate. So seize those opportunities.
Perfect. That's a good piece of advice. And speaking of advice, do you have anything else that you would say to a medical student or a junior doctor who's feeling overwhelmed at not really knowing what specialty they want to pursue?
Yes, don't worry about it.
Mm.
It's easier said than done, but don't, because it'll work itself out in time. And I think you always have to remember that it takes each one of us different lengths of time to work out what we want to do and where we'll be happiest working. I look back to med school, and maybe the same for you, Chantal. There's people in their first year, they knew they wanted to be an orthopedic surgeon, or what have you, and that's what they are now. I didn't have a clue. I barely knew my way through medical school, let alone what was going to happen after that. And I think we mature at different rates anyway. And in medicine, it's probably the same in terms of our experiences. So don't pressurize yourself too much. I think one weakness of the system now is it's a bit too rigid. Going back sort of 20 years ago, you could have chosen to do SHO jobs for several years and complete range of things you wanted to do for however long you wanted until you found something suitable. Whereas now it's kind of you do F1, F2. I think that's why people are taking a year out. Sometimes they don't know what they want to do. They need that flexibility. So just take your time. And if you have to do or extra standalone jobs in that time, that's absolutely fine, because no experience in medicine is ever wasted either. So whatever job you do, you'll take something useful from that, and it's all practice in medicine, which is what we're about, really. So don't worry about it. Just keep pushing at different doors, keep trying to take different opportunities, seize them for different jobs, speak to other people, and you start to get a feel with time what you want to do. But as I said earlier, try and choose something that's going to challenge you, keep you interested, and try and choose, definitely choose something that you're going to enjoy.
Mm.
And if you enjoy your job, it's not like you don't really work.
Yeah, which is
Almost.
important, because when it gets stressful, you remember why you're doing it.
Mm,
I don't know. I think the problem is that we try to get the fastest way to do something. And that's why medical students, especially my colleagues and I, we get really stressed because it's like we have to have a decision straight away. And when we don't, that's when it gets difficult and overwhelming. But I'm glad that you said it's okay to, open different doors, try different paths. And if anything, you can change later on down the line. So that's a promising response.
yeah, nothing is set in stone. And although the system seems a bit like that, there are always options, and people switch across different routes, and things happen in life, and you have to reevaluate what you're going to do in terms of medicine as well. So it's all those things, but yeah, give yourself the time.
Perfect. And I have two more questions. One is the closing question that I ask everyone, and the other one is what we call the featured question, where I get a listener to just ask us anything and I'll ask you.
Okay.
So the featured question is, what is the most common myth about endocrinology?
I would say that I've got to be careful, I'm not going to offend colleagues here. I would say it's actually that it's not all diabetes and all to do with sugar. I think lots of
Mhm.
people think, oh, that's just diabetes, that's sugar. And that's what we see on the ward, just diabetic foot ulcer, occasional DKA, people with hypos, insulin. Whereas actually, it's because I'm an endocrinologist, it's fascinating, the endocrine aspects, the whole array of, as I say, pituitary disease, adrenal disease, gonadal disease, inherited disorders. So I think that's probably one of the biggest myths, and one of the biggest myths is purely because that's what juniors are seeing on the ward. So if you take up a job in D&E, actually you'll be on a ward with general medical patients, and you'll think that is what D&E is all about. So maybe not even just sugar-based, but your perception of the specialty will be probably wrong unless you come to outpatient clinics. So remember, it's an outpatient-based specialty. Come to clinics, sit in, and be inspired.
I love that you said it's not all about diabetes because when I went into medical school and I heard endocrinology, that's actually the first thing that I thought. So it's quite
Yeah.
ironic that you said that. And since I've gone through the years, we've learned about more pathologies and conditions. Um, but I can definitely agree that that is a common myth.
Mm.
Um, and for our closing question, what is the best piece of advice that you have been given that has shaped you as a clinician?
Ooh, it's a good question. Um, I think a good piece of advice has always been never get to the state when you think you have to know everything. In other words, don't be afraid to say you don't know and to ask. Um, we can't know everything as a clinician, and there are difficult cases. And sometimes we get a bit proud and we think, oh, we should know this, or pretend to know it. But actually, it's far better. And that's being a good doctor, isn't it? You're being honest with yourself and with the patient, and you're drawing from the team, you're drawing from other people's experiences as well to ask for advice. So, and don't be afraid, therefore, to ask people, what's the latest guideline in this? I read it, recognize what that drug is, be humble enough, I think, to know your limitations.
Mm. And that's especially important when we're considering, patient safety as well. So it's kind of setting our egos aside and just saying,
Mm,
don't know, but you will figure it out. You will learn more about it.
yeah. And always remember that we're there for the patients as well. I think that's key, isn't it, in medicine? We're the patient's advocate, we're the patient's friend,
Mm.
which I don't think there's a lot about AI these days,
Yeah.
trying to replace those. And it will have a role, definitely, but it can't replace a human who can see another human suffering. And I think being that compassionate doctor and who listens well, and that's another thing, listen well to patients, and try and understand them. And I think if you can listen well and just develop that rapport with a patient, get that trust, that they trust you, you've won a lot of the battle, really. Not that it's a battle with patients, but you've won a lot of that relationship, and you can then work with them. But I think if you don't listen, if you don't respect the patients wherever they're coming from, you're pretty much lost straight away.
Mm. Perfect. So those are two golden nuggets that I hope listeners will take away as well. And that brings us to the end of the podcast. So thank you so much for speaking to us today. I now have
Thank you
more
very much.
Yeah, I now have more insight into endocrinology, and I'm sure that the listeners will as well.